Hi guys, welcome back. The topic that I'm going to teach you is disorders of the parathyroid gland, but we'll first focus on the basics with respect to parathormone, FGF23, that is fibroblast growth factor 23, and calcitonin, which has the limited physiological role in humans. When it comes to PTH, the first detail I want you to remember is that this would be 84 amino acid sequence, just like insulin would be 51 amino acids. And now let's look at functions of PTH in the body. And one would be that if there is less calcium in the blood, then PTH will act on the bone. It's gonna cause a enhanced bone reabsorption, and it will try to stabilize the serum calcium values. The second function of parathormone would be that it will try to enhance the calcium reabsorption via the distal tubules in the kidney. I repeat this fact once again. PTH is to stabilize serum calcium. How would it do it? Two ways. One is to enhance bone reabsorption from where the calcium would be coming, and second would be from the kidney per se via the ultrafiltrate. There would be increased calcium reabsorption per se via the distal tubules. And there is a special sensor which is also present here. The name of this sensor that I would like you to remember is CASR, that is calcium sensing receptor. And abnormalities of this CASR is what we're going to discuss subsequently. But at the moment, all I can say is if this CASR malfunctions, you tend to have is an enhanced reabsorption of calcium from the distal tubule, and this spikes up the serum calcium values and would contribute to hypercalcemia, because I'll be describing diseases before you where hypercalcemia would be present. And one would be obviously PTH increase, another one would be malfunction of CASR. The technical details I'll be jotting down as and when I summarize the causes of hypercalcemia. The second action of PTH is again on the kidney, and this time it would be acting on the proximal convoluted tubule. By acting on proximal convoluted tubule, what this is doing is it's trying to regulate phosphate values as well. What this will promote is phosphate wasting. And why that is important for us to know is because of the fact that suppose I give you a situation where PTH in the body is more, then if PTH in the body is more, it will obviously cause an enhanced bone reabsorption, which will increase serum calcium. It will also increase reabsorption by the distal tubule. The values of calcium will spike once again. But once it will act on the proximal tubule, it will also cause a phosphaturia, and therefore phosphate values will reduce. I want you to remember that PTH always causes calcium and phosphate values to have an inverse relation. This will help you or will make your life easier when it comes to these multiple choice questions with respect to hyperparathyroidism and hypoparathyroidism. Like in hypoparathyroidism, if PTH is lesser, then action number 1 would not happen properly, or in lesser amounts, so calcium would be less, and this phosphaturia component would be reduced, so serum phosphate levels would be relatively increased. The third action of PTH would be that it would be affecting bone turnover, and the marker of bone turnover which you need to remember is serum alkaline phosphatase. So every time you have is a hyperparathyroidism, serum alkaline phosphatase values would be increasing. At this junction, I want to tell you that what cell is responsible for production of serum alkaline phosphatase. Then we have two cells in the bone. One is osteoclast, which is responsible for bone destruction. Second is osteoblast, which is responsible for bone formation. So which cell would be responsible for serum alkaline phosphatase production? Then your answer would be given as osteoblast. I repeat once again that osteoblasts are the ones which produce serum alkaline phosphatase. And when I describe it, most students say, sir, it does not make sense, because on one hand you are saying bone reabsorption. Bone reabsorption is a function of osteoclast, and osteoclast is not producing SAP. So how SAP values will increase in a patient of hyperparathyroidism? Well, the logic is that PTH will cause bone reabsorption, so it will cause activation of osteoclasts. And if osteoclast will be working more than normal, then there will be a secondary activation of osteoblasts as well. And the secondary activation of osteoblast will explain the rise of serum alkaline phosphatase. At the moment, you need to remember minimum at least two aspects. Bone reabsorption thing is very straightforward. I want you to remember PTH via the distal tubule tends to increase calcium, and via action via the proximal tubule tends to decrease the value of phosphate, which is why every time we are having a PTH problem in a patient, whether more or lesser, calcium phosphate values would always be having is a inverse relation. The next thing on the agenda on this particular slide would be details with respect to FGF23, which again will be playing a role in regulation of calcium and phosphate. Well, the full form here for FGF would be fibroblast growth factor. And first time when we read the word FGF full form per se, I mean, the impression is it regulating calcium phosphate? I mean, seriously, but yes, that is true. So apart from PTH, I want you to remember that fibroblast growth factor 23 regulates calcium phosphate metabolism. And if he says what's the primary action of this hormone, then there are two aspects which are to be remembered. Just like I was telling you with respect to PTH, two actions with respect to FGF is one, FGF will be causing is suppression. I'm not saying that it is antagonizing. Antagonism role is obviously of calcitonin, but then suppression of PTH is one of the functions of FGF23. And the second function would be phosphate loss again. This is also a phosphaturic hormone. So I want you to remember that both PTH as well as FGF per se would be contributing to phosphate loss from the body. They're regulators of phosphate metabolism. And every time you have an abnormality with respect to these hormones per se, then elevated phosphate / elevated calcium, either of the two. It's not only calcium increase that will cause kidney stones or nephrolithiasis. Whether calcium is more, whether phosphate is more, you can be either of the two increasing can contribute to nephrolithiasis in a patient, and that will again come in handy as we progress in our discussion. When it comes to the third hormone, calcitonin per se, I can say that this would be having is a limited role when it comes to humans. But yes, we do use it therapeutically for management of hypercalcemia and even in patients of osteoporosis for especially reducing the bone pain component. I mean, yep, calcitonin is used in osteoporosis, but not to basically improve the bone density per se. The major role would be to have an analgesic effect and reduce the bone pain in the patient. I repeat once again, calcitonin per se would be having is a limited I mean, that's what the textbook says, so I have to replicate that statement, limited physiological effect. And what it is going to cause is that it will, how does calcitonin act in osteoporosis? So it will act in osteoporosis by inhibiting the osteoclastic mediated bone reabsorption. If you inhibit the bone reabsorption per se, even if you're not adding to the bone strength, I can say you are preventing its deterioration. So calcitonin may not have a very significant role in improving bone density. Like bisphosphonates, they cause an increase in the bone density on a follow-up. Calcitonin may not show a very substantial or hardly show any effect on the bone density, but at least it will prevent the deterioration. The second action of calcitonin would be it tends to increase calcium renal clearance. When I say the word clearance, it will contribute to loss of calcium via the kidney. See, PTH was causing reabsorption of calcium by the distal tubule, whereas per se calcitonin, what it's gonna do is that it will promote urinary loss of calcium. Calcitonin can have tachyphylaxis as well. It has limited effects in a sense that tolerance develops to the effects of calcitonin very, very soon. And the third point is anyway a quick revision for you that calcitonin is also a tumor marker for medullary carcinoma of the thyroid. And MTC plays an important role in endocrinology because it's a component of multiple endocrine neoplasia. So especially MEN2 is where we study about it, and it happens to be a tumor marker and does not contribute to hypocalcemia there. As far as the calcium sensing receptor is concerned, it is not only present in the kidney per se. I mean, not only will it be regulating the calcium values, but castor is also present on the parathyroid gland. So I can say that if calcium in the blood is less, what is that sensor that will regulate that, okay, there is less calcium in the blood? The name is calcium sensitive receptor, and then it will stimulate the parathyroid gland per se to produce excess of PTH. And this would affect serum alkaline phosphatase values also. So a quick recap for serum alkaline phosphatase. Though you guys are gonna read about serum alkaline phosphatase being produced even from the liver, and liver specific alkaline phosphatase is elevated in obstructive jaundice, then bone specific alkaline phosphatase is what I am primarily talking about. And serum alkaline phosphatase is also produced by the placenta, but it does not have any therapeutic or I would say it does not have any diagnostic importance. Conditions which you are going to read where serum alkaline phosphatase is going to be elevated in pediatric age group is rickets, that is nutritional rickets. So I'm going to talk about dependent rickets type 1 and 2 as well subsequently. A quick recap: elevated SAP would also be encountered in vitamin D deficiency in adults, which would be osteomalacia. Remember, in osteoporosis, SAP is normal. It's not affected in because osteoporosis is due to increased activity of osteoclast, and SAP is not produced by osteoclast. SAP is produced by osteoblast per se. So values of SAP are normal in osteoporosis but are elevated in patients who are having, let me say, a parathyroid adenoma, and this would cause hyperparathyroidism. Whether it is primary hyperparathyroidism due to a parathyroid adenoma, whether it is secondary hyperparathyroidism due to chronic kidney disease, or whether it is tertiary, the point is in all of them, serum alkaline phosphatase would start increasing. Now, in the exams in the previous years, they have asked serum alkaline phosphatase is reduced in, and the first impression in our mind as a doctor would be that if elevated PTH will cause increase of SAP, then low SAP should be seen with hypoparathyroidism, and that is where we commit a mistake. I want you to remember that decreased serum alkaline phosphatase is not to be answered as hypoparathyroidism, but rather a rare condition by the name of hypophosphatasia. So please curb that impulse of answering low SAP for hypoparathyroidism. Your answer would be for low SAP be given as hypophosphatasia. On this, the query of most people is then, boss, what would be the value of serum alkaline phosphatase in hypoparathyroidism? Well, your answer would be values of SAP would be normal, and this would again come in handy. Like I was telling you, calcium phosphate having an inverse relation, calcium being reabsorbed by the distal tubule, phosphate being lost by the proximal tubule. All these things will come in handy in the MCQs. And now I mentioned another useful point. Normal serum alkaline phosphatase is encountered in patients of hypoparathyroidism. Apart from this, I have already sensitized you to the fact that osteoporotic patients again would be having is a normal SAP. So, serum calcium phosphate SAP have no diagnostic importance when it comes to osteoporosis. And serum alkaline phosphatase is also increased in a condition where you have osteolytic lesions, raindrop configuration of punched out lytic lesions in the skull in multiple myeloma. The message is normal values would be encountered in the 3 points that I've said, and then could be a disproportionate rise of SAP. Disproportionate rise of serum alkaline phosphatase would be encountered in patients with Paget's disease. These are 4 points that would help you in multiple choice questions. And these 2 slides that I've discussed before you here are normal actions for various hormones related to calcium metabolism that one should be comfortable with, so that we can work out now manifestations of primary hyperparathyroidism. Now, in primary hyperparathyroidism, let us assume this to be 4 parathyroid glands. We usually tend to have is a adenoma or a tumor in the inferior parathyroid glands, though it can arise in any one. But this is what the textbook says, that mainly the parathyroid adenoma tends to arise in the inferior parathyroid glands per se, though you could be having is a parathyroid carcinoma as well, but most of the time it's gonna be an adenoma. And from the histopathology perspective, the main cell which would be causing the problem here would be chief cell. So the first 2 points that I've said is mainly from the location perspective and from the histopathological perspective. And now let's look at what is actually gonna happen to the patient. Once the values of PTH will spike, you will notice that the calcium values will start rising in the patient. Normal calcium values are in the range of 9 to 11 milligram%. And in these patients, you could be getting is a value which could go up to 15. Why am I worried about a calcium values as high as 15 milligram% is that there is a possibility of a cardiac arrest. Yes, guys, hypercalcemia that can occur due to any of the conditions that we're going to discuss. Primary hyperparathyroidism is one of them. If it's undetected, calcium value spike, person can die as well. The usual age of presentation in parathyroid adenoma, which is contributing to primary hyperparathyroidism, would be in the 3rd to the 5th decade of life. And let us now look at why this person would come to you. And one broad term that I can describe for this individual who is either having a solitary adenoma. One possibility is one of the parathyroid glands, there is a tumor. Sometimes these patients could be having is an association with multiple endocrine neoplasia. When you listen to the MEN syndrome, there are 4 varieties of it. Then you will notice that parathyroid adenoma will be occupying its position in both multiple endocrine neoplasia type 1 as well as in multiple endocrine neoplasia type 2, but not in MEN 3/ which is formerly called as MEN 2B. And that was actually a neat PG question, pretty straightforward one. You see, the older terms are MEN 2A and MEN 2B. The message is you do not get primary or you do not get a parathyroid adenoma with patients who are having a MEN 2B, which is gonna be currently called as multiple endocrine neoplasia type 3. But the main objective of telling you this is that people could be having a concomitant, like in MEN 1, patients could be having a concomitant Zollinger-Ellison syndrome as well. Or in MEN 2, there could be a concomitant pheochromocytoma as well. That could explain the hypertension developing in these patients. I am assuming that my patient is having a solitary adenoma, and the highlight, I mean, how you remember this is that there would be bones and stones. Why there is bone pain is explained already. There would be lytic, I would say there would be enhanced bone reabsorption, which will explain the bone pain developing in these patients. And you read that classical term, though it's very rare nowadays because we are able to diagnose this condition early. But in pathology, you read the term osteitis cystica fibrosa. When I say cystica, that means cyst in the bone. So why that is happening? Because there's an enhanced bone reabsorption thanks to this parathyroid adenoma, solitary adenoma, or could be associated with multiple endocrine disorders as well. Once the calcium values will spike, it will contribute to a possible renal colic and hematuria in the patient also because of nephrolithiasis and stones. Plus, these patients would also get psychiatric manifestations. So we read about moaning and groaning. These moans that I have written at the moment are mainly psychic in origin. So we would be talking about, I would say, manifestations like depression developing in these patients or frank psychosis developing in these patients. And apart from this, another problem would be abdominal pain. There are multiple reasons for abdominal pain, like you could be having peptic ulcer disease in these patients, or you could be having constipation in these patients. That would explain the groans component in the patient. So the groans are mainly because of the issues coming from the abdomen, and the moans are mainly from the, I would say, the psychiatric component. So if you get these words right, bones, stones, moans and groans, then primary hyperparathyroidism would make sense, though I'll try to describe it more in detail as compared to what I've said at the moment. So once the calcium values will spike, let's say patient is having, at the moment he's undetected and the calcium values have increased to 11 to 12 milligram %, then why would he come to you is primarily because he could end up with nephrolithiasis, he could end up with renal colic. That could contribute to severe flank pain radiating to the umbilicus if it's a concomitant ureteric stone as well. Getting stuck up in the lower 1/3 of the ureter, the pain could be reaching to the genitals, to the tip of the penis, or even going up to the scrotum or vulva in a female patient. So every time you are having this renal colic, the stones which are going to be developing here are mainly calcium oxalate, or it could be calcium phosphate. I repeat once again, either calcium oxalate or calcium phosphate stones would be developing in these patients. So that will explain the renal colic component. And because the calcium values are spiking, then calcium can also contribute to development of ileus. When I'm saying calcium is causing ileus, the query of most people is, sir, we have read hypokalemia will cause ileus. You were saying calcium will cause ileus. Then I can say that this is going to cause mainly problems with the sphincters of the gut. The sphincters of the gut are not going to be able to relax. So the intestine will get tired by working against these tonically with sphincters whose tone is constantly increased, and you have is a calcium induced ileus. And the manifestation of this would be abdominal pain because person would be having is a constipation on a regular basis. And this constipation usually would be having a limited response to laxatives. Then when calcium tends to increase, it also tends to cause stimulation of parietal cells. You know, in GI, you always study hypercalcemia can cause stimulation of parietal cells, and therefore there can be increased acid production. And once there is an increased acid production, there is increased risk of peptic ulcer disease. So one, I want you to remember that apart from the flank pain radiating to the umbilicus, even epigastric pain should be present in these patients. More importantly, if a person who's having a parathyroid adenoma is having a concomitant multiple endocrine neoplasia type 1, then the pancreatic adenoma that will occur here will be Zollinger-Ellison, and Zollinger-Ellison will be producing even much more amount of acid, and that could contribute to even a perforation. I mean, you read in MEN 1, though I've discussed multiple endocrine neoplasia separately, I've said in multiple endocrine neoplasia type 1, the cause of death is mainly peptic ulcer resulting in a perforation in the gut. So the message is you would be having is multiple reasons for abdominal pain. Apart from kidney stones, there is a constipation component present, there is a peptic ulcer disease, and it could be recurrent multiple peptic ulcers that or a giant duodenal peptic ulcer. That's because of concomitant Zollinger-Ellison syndrome developing in these patients as well. And as the calcium values will rise even further. If he says what is severe hypercalcemia, then severe hypercalcemia would be described as calcium values between 13 to 15. And this kind of a presentation is a little rare nowadays because most of the time we are able to diagnose this condition early. But as I said, I mean, in earlier times when the diagnosis was made late, then we used to read about this presentation, that is osteitis cystica. I mean, the word cystica fibrosa tells you that there is destruction of the bone due to excess of parathormone to the level they could be bleeding in those cysts also. And then bleeding will contribute to hemosiderin production, and hemosiderin is brown in color. So the pathology person would teach you brown tumor for osteitis cystica fibrosa. But at the moment, I said this kind of a presentation on a relative basis would be, I would say, I mean, with a third generation PTH assay available now, or a second generation PTH assay available now, this manifestation of at least osteitis cystica fibrosa presentation would be less common nowadays. Then apart from this, patients would be complaining of difficulty in climbing stairs. When you do examination, you will notice that most patients who are having hypercalcemia due to hyperparathyroidism would be having a proximal muscle weakness. And you can see the problems are mounting. The abdominal component was anyway present, peptic ulceration was occurring, bone pain was present, muscle weakness is coming up. So you will notice that these patients will develop a psychiatric component as well at this point of time. So depression or psychosis, which will explain that I would say the moaning component that I was describing before you. And why I'm worried about these patients is that if diagnosis is not made, then the unfortunate bad news can be that this person can expire. In fact, that's a standard question that you need to remember, that if calcium values go in excess of 15 mg/%, then possibility of systolic arrest in a patient would be substantially high. Now, before I go into the workup of a patient who's suffering from this problem at the moment, that would be the clinical profile like the one that I've described, I would like to use this opportunity to also mention, I mean, this is the profile. I'll repeat that again: the stones, bones, moans, and groans in a patient. In this kind of a profile, I will be doing a very specific workup of the patient, including a nuclear scan to pick up the adenoma. But I will like to, at this point of time, try to make the discussion a little more broader by incorporating a couple of causes of hypercalcemia. I'll do an ink change here because this would be some miscellaneous information that I am incorporating at the moment. And once I come back to hyperparathyroidism of the primary variety, I'll resume by discussing in color white only. So why do you have is a hypercalcemia? One of the reasons for hypercalcemia where persons will become symptomatic very fast would be any kind of a malignancy. The term that will be used in the MCQ to make it sound sophisticated, cancer contributing to hypercalcemia, the technical term would be HHM, that is humoral hypercalcemia of malignancy. Now he would like to ask you which cancers have you read. I mean, paraneoplastic syndrome coming up in the discussion once again. He would expect you to remember that which cancers are the ones which are associated with development of hypercalcemia. Then one, I want you to remember that the tumor that I described to you is not producing actually true PTH. It is producing PTHRP, which is parathormone related peptide. PTH, you understand, parathormone, R is related peptide, and the cancer that I'm talking about is a lung cancer by the name of squamous cell cancer. You know that when it comes to paraneoplastic manifestations, lung cancers are always going to take a lead. And every time we read about paraneoplastic, first thing that comes to our mind is OAT cell. OAT cell is related to SIADH. OAT cell is related to Cushing syndrome. I repeat again, OAT cell cancer, small cell cancer, most aggressive lung cancer, it's related to development of Cushing syndrome, related to development of excess of ATH. That's why there is a Cushing syndrome, or excess of antidiuretic hormone contributing to SIADH. But squamous cell cancer, if you read that, your answer would be this is related to release of PTHRP. It's not true PTH. It looks like PTH. It behaves like PTH. It comes from the cells of lung cancer, that is squamous cell cancer. The second example that I wanted to remember is breast cancer. So these are like two cancers, I would say, which contribute to hypercalcemia, which will become symptomatic very fast. And if diagnosis is not made, the person will not only die because of the detrimental aspects of metastasis, but even hypercalcemia can be worsening the condition of the patient and contributing to a possible systolic arrest. Then would be the topic that we are studying. A person could be having is a parathyroid adenoma. In fact, lots of time parathyroid adenoma patients may initially remain asymptomatic. It's only after a time, if the diagnosis is not made, that these patients start having that stones, bone pain and groans and bone manifestation. Most of the time, there's a possibility that parathyroid adenoma initially might remain asymptomatic. So I'm also going to teach you, what is the frequency of screening? Like you did a evaluation and you done a annual medical checkup in a patient and the blood work is showing grossly elevated calcium. But person is not having any symptoms. So you need to know how frequently should you monitor the patient lest he deteriorates. So, the details of parathyroid adenoma will come back on the slide. But at the moment, my objective is to sensitize you to causes of hypercalcemia. I said patients will become symptomatic faster with malignancies when it comes to hypercalcemia symptoms, whereas parathyroid adenoma is going to be benign. It's going to take a longer time to grow. Then would be a very important cause from MCQ perspective, that is sarcoidosis. You're aware that in sarcoidosis, we would be having is development of non-caseating granulomas. And the speciality of these non-caseating granulomas is that they can synthesize vitamin D3 because they have this enzyme 1-alpha hydroxylase. So as a result of this, there can be synthesis of vitamin D3, and vitamin D3 will then contribute to enhanced intestinal absorption of calcium and will increase calcium values, contributing to hypercalcemia in the patient. Why am I teaching you regarding sarcoidosis suddenly in between while describing parathyroid adenoma is because if the cause of hypercalcemia is parathyroid adenoma, which is very slow growing, you might have to go ahead with surgery and resection of adenoma. But if person is having sarcoidosis, then you need to give steroids. Yes, guys, the MCQ that I'm trying to sensitize you at the moment in between my discussion of primary hyperparathyroidism is steroid responsive hypercalcemia. Steroid responsive hypercalcemia, the first thing that should come in your mind at any point of time would be sarcoidosis. I'll write that statement in a while, steroid responsive hypercalcemia. Let's look at another situation. This guy, he's taking excess of vitamin D, maybe in his gym supplements. Vitamin D intoxication. You can understand vitamin D causes increased enteral absorption of calcium. Like I was teaching you, PTH is promoting calcium reabsorption from the kidney. I'm teaching you at the moment vitamin D3 is promoting calcium reabsorption via the gut. So if a person is having vitamin D3 intoxication, this is again going to contribute to increased enteral absorption of calcium and a hypercalcemia manifestation developing in a patient. The fifth patient of mine who's having high calcium values is abusing antacids. These antacids would also be having is a high component of calcium carbonate. That calcium component would contribute to development of hypercalcemia. The term that we use to describe this is milk alkali syndrome. This is itself a question. Milk alkali syndrome is seen with, your answer would be simply antacid abuse, because antacids would be having calcium carbonate, the calcium values would spike in the patient. For the sixth condition, I want you to pay, I know you're paying attention, but I want you to pay more attention because of the specific name coming up, Jansen disease, which is the autosomal dominant condition responsible for hypercalcemia. Now listen to the details very carefully. In this condition, the problem is not of PTH. The problem here is with respect to PTH receptor. Like I'm just mentioning one of the PTH receptors there. Don't talk about Caspar at the moment. Caspar is a sensor to regulate the release of PTH. It's a sensor on the parathyroid gland, sensor in the kidney to regulate the calcium values in the blood. At the moment, I'm not talking about a sensor. I'm talking about the receptor for PTH. Now, in Jansen disease, what happens is that this receptor per se, this exhibits a gain of mutation. I'll draw parallels here. Like if you've listened to my discussion with aldosterone, I've talked about Liddle syndrome. Liddle syndrome problem is not of aldosterone, but the receptor for aldosterone, ENaC, is working more than normal. And therefore, there is more absorption of salt and water. Similarly, here what I'm saying is that there is an activating mutation of this particular PTH receptor. So even without PTH, the receptor is working. You see, normally the receptor has to be stimulated by a hormone and then the receptor should be working. But here this receptor is working more than normal. So it will contribute to increased, if the receptor will, PTH after all has to produce. So PTH has to produce physiological effects. And the physiological effect would be that there would be a hypercalcemia developing. Though the PTH is directly not responsible, it is the receptor that is working overtime at this moment. And when you're going to evaluate the patient, PTH values by feedback will be less, because when calcium rises, PTH will become lesser. I repeat the fact here, the problem is not the hormone. Hormone is shockingly less. So you anticipated hypocalcemia. That's the point I want you to remember. If PTH is given less in any question, your thought process is patient should be having hypocalcemia. He will say hypercalcemia. Why that is happening is because of the fact that in this particular chap, what happened was this particular receptor for PTH is having an activating mutation. It is working more than normal. The word is gain of mutation. Like in Liddle syndrome, ENaC is having a gain of mutation. Here, this PTH receptor is having a gain of mutation, as the result of which the physiological effects of PTH will be occurring or will be accentuated. And that is why hypercalcemia occurs. And this would be a autosomal dominant condition. The seventh cause why you can get a hypercalcemia is with a drug, that is lithium. So just like you are aware, lithium causes nephrogenic diabetes insipidus. That's important question. I'll repeat that again. It's discussed in diabetes insipidus section as well. Lithium causes nephrogenic diabetes insipidus. Similarly, lithium can cause activation of parathyroid gland. It can activate the parathyroid gland and can cause hypercalcemia. When you will discontinue lithium, the hypercalcemia component will begin to regress. Traditionally, when we study the side effects of lithium, we study tremendously regarding the nephrogenic diabetes insipidus component, but I want you to remember it can also contribute to development of hypercalcemia. And for the eighth point, I want you to listen with more care. Obviously you're listening to me with care, but I want you to listen with even more care than what you're doing at the moment. The condition that I'm telling you at the moment is again autosomal dominant. The problem here is with respect to CaSR, calcium sensitive receptor. This calcium sensitive receptor is located in two areas. One is parathyroid and second is in the kidney. The bottom line is, if this CaSR will malfunction, we are having is a loss of function of the sensor. The sensor is telling parathyroid gland there is no calcium, and how do parathyroid gland respond? Okay, release more PTH. Repeat once again, because there is a malfunction of the CaSR, the parathyroid gland will be under an impression that there is no calcium in the body. Calcium is there, but the sensor is not working. So the gland will be under an impression that, okay, man, there is no calcium in the body. So parathyroid gland activity will increase and it will start producing excess of PTH, and more PTH, what it will do via the kidney, it will try to reabsorb more of calcium. And because there will be more calcium reabsorption via the distal converted tubule, the blood calcium will begin to rise. Repeat once again. What happened was CaSR. Sensor is saying, sir, there is no calcium. Parathyroid gland says, oh, there is no calcium. Let me increase my activity and release more PTH. When there will be more PTH, this will cause more calcium because it will reabsorb it from the kidney, and therefore hypercalcemia will occur. I can explain this another way as well. The CaSR is present in the kidney also. The bottom line is, the signal in the body is less calcium. The CaSR is not working properly. So the kidney will try to upgrade calcium reabsorption. I told you two reasons why there is a calcium reabsorption increasing. One is with relation to the PTH doing its routine activity. Second, I said CaSR is present in the kidney also and regulates calcium. Even the kidney is getting that feeling, oh, there is no calcium in the body. So how will the kidney respond? Try to reabsorb more of calcium via the tubules per se. So ultimately what will happen in the patient would be that the urinary calcium values will become lesser. Why? Because all the calcium is going back. Because all the calcium is going back, so the term used would be hypocalciuric. Why? Because urinary calcium would be less and in the blood is rising, that is hypercalcemia. Guys, the condition that I'm trying to teach you at the moment is an autosomal dominant condition called as familial hypocalciuric hypercalcemia. Let me explain the problem here once again. Due to genetic reasons, there is a Cassar malfunction. The calcium sensing receptor is telling there is calcium in the body, but it is giving a signal to both the parathyroid glands in the kidney that, sir, there is no calcium. So both of them will say, oh, we will try hard to increase the calcium in the body because that's the job of parathyroid gland. And similarly, the calcium will try to reabsorb all the calcium. Once you send all the calcium back into the blood, what happens to calcium in the blood? Rises, but the urine, if you check out the 24-hour urinary calcium in the body, it would be lesser. So the term is FHH, that is familial hypocalciuric hypercalcemia, which is again autosomal dominant. 6 and 8 are relatively rare diseases and rare causes for hypercalcemia. But because they love to ask about these I would say rarer aspects. So it's a good effort to remember the 8 points that I have explained intermediate for hypercalcemia. And with respect to point number 3 and 4 at the moment, I also want you to remember that these patients, we shall be using steroids like dexamethasone. So the term used in multiple choice questions would be which of the following condition or conditions, because sometimes you could be having multiple responses also. So he will say which of the following conditions would be called or categorized as steroid responsive hypercalcemia. I'm going to teach you 3 conditions. There are 2 at the moment. I'm going to teach you 3 conditions today in this video, which is steroid responsive hypercalcemia. Out of 3, 2 have been told to you. I hope it's a permanent visual memory for you at the moment. So, I mean, doctors are supposed to have a photographic memory. So I hope you remember point number 3 and 4, sarcoidosis and vitamin D3 intoxication. We will now focus on workup of a patient of primary hyperparathyroidism, the patient with stones, bones, moons and groans. So I'm going to run a serum calcium phosphate and serum alkaline phosphatase in the patient. And because PTH is more, so calcium will be more. Calcium and phosphate have an inverse relation. I told you it causes phosphate loss by the proximal tubule, so phosphate would be less. And because bone turnover would be enhanced, serum alkaline phosphatase would be elevated. The moment I am going to see this report, the test that I'm going to write for this patient is a serum PTH assay. You see, serum PTH assay test per se has itself undergone a lot of evolution. In the textbook, you will read about like a 2nd generation or a 3rd generation kits available. So you should be, telling the lab to use the latest kit, whichever is available, and serum PTH assay would be showing a tremendous rise in the value of parathormone. And then you need to localize the adenoma. The question will say, which of the following radionuclide scans would be useful for locating a parathyroid adenoma? Then your answer would be given as technetium-99, that is SYSTA-MIB scan. Please remember that technetium-99 scan or SYSTA-MIB scan is a radiological parameter to localize. It's an imaging modality, I'll say like this, to localize a parathyroid adenoma. Do not call this as the best way for diagnosis, because for diagnosis you need multiple things. Apart from clinical profile, you need elevated PTH in this calcium phosphate profile. But to localize the adenoma, the imaging modality that you shall be using would be a SYSTA-MIB scan. And once the diagnosis of the person has been made, then subsequently what we need to do is go ahead with the parathyroid surgical resection. While doing multiple choice questions, just be a little alert to the fact that easy writing technetium-99 plain or easy writing technetium, because these one-liner questions, most of the time I'd say for those longish questions, clinical vignettes is still easier to comprehend. But every time you read about a technetium-99 per technet scan, then this is, I'm writing in a separate color, is what you read in pediatrics. This would cause possibly a hematochezia in a kid as well. That would be technetium-99 per technet scan is the imaging modality of choice for identification of Meckel's diverticulum, and that would be a miscellaneous information that I would like you to remember. To aid you with the diagnosis in the question, he might even mention regarding the effect of PTH, like every time you do X-ray hand of these patients, because PTH is more, it will cause a bone reabsorption. So he might actually use this word by himself, subperiosteal reabsorption of phalanges. In fact, lots of time, every time you're doing a hyperparathyroidism MCQ, this term would always be present in most of the questions. Now comes, what are you going to do for this patient? Then I've already told you that if it is an asymptomatic patient, we just need to screen the patient. But if it is symptomatic, then treatment has to be done in the patient in the form of a surgical exploration and resection of an adenoma. I mean, the preferred, I am assuming that my patient has been documented. Let me say it's maybe only a 0.5 centimeter or maybe a 1 centimeter adenoma, but here it is not about size. It is about the hormone that it is producing. So exploration of the neck would be done and the tumor would be resected. What are the indications for surgery? Because you are not going to operate on an asymptomatic patient. Indications for surgery, you don't need to remember for exam for a parathyroid adenoma. But I mean, in your exam, he has more common things to ask you, like indications of surgery with respect to thyroidectomy, like maybe a total thyroidectomy or let me say subtotal thyroidectomy. So here you need to just listen to this aspect. I mean, if I have a patient who is relatively younger, I mean, in older patients, because of comorbidity, surgery of the neck might be a little risky. But in a younger patient, if you're documenting that there is a elevated calcium, which is contributing to damage to the kidney, how do I know that damage to the kidney is there? I'll get a eGFR calculated or I'll get a creatinine clearance done in the patient. If in a relatively younger patient with elevated calcium, I notice that the creatinine clearance of the patient is less than 60 ml per minute, then this person's lifespan would be reduced if we do not intervene, and that is why surgical intervention would increase the lifespan of an individual. Apart from this, another test that can supplement my decision would be a 24-hour urinary calcium values, because if calcium is more in the blood, then 24-hour urinary calcium would be elevated as well. Similarly, if I've done a bone densitometry in a patient, the test that we do is a DEXA scan. You know that we do regularly a DEXA scan in osteoporosis patients, but in hyperparathyroidism patient also I have done a bone, I want to check bone density. So to check a bone mineral density by DEXA scan, if I document that the T-score of the patient is turning out to be less than minus 2.5 standard deviation, it means the damage is already present. Or in some patients, there might even be a vertebral fracture. I mean, little less rare, but I told you that lesion, no? Osteitis, cystica fibrosa. So the damage in the bone can be so extensive that you could be having a pathological fracture of the vertebra. So these are situations where surgery would be required in a patient. And in case we are having a asymptomatic parathyroid adenoma at the moment, I mean, it was just detected on annual medical checkup where serum calcium was elevated, or there might be some complaints like constipation occurring in a patient due to elevation of serum calcium. So in this particular chart with asymptomatic parathyroid adenoma, if he says, what are you going to do? So you just going to monitor the patient on an annual basis and check out his KFT, check out his estimated GFR values, 24-hour urinary calcium. So annual monitoring is the one which would be recommended at the moment. I mean, let the patient earn his surgery. I mean, in endocrine, we always say like this, that let the patient earn his surgery. And even if you don't remember this slide, doesn't matter. You should be rather more comfortable with indications for surgery in a patient who's having, let me say, Graves' disease. So relatively more common indications to surgery would be asked to you. Now, since I've described various causes of hypercalcemia to you, so it will also be prudent to explain to you how would you manage a patient of hypercalcemic crisis. I mean, medical management of hypercalcemic crisis has also been frequently asked in the exam. The reason why we're studying this is that if you do not intervene in a patient who's having a serum calcium of 13, going on to 14, going on to 15, there's a possibility of a cardiac arrest and a systolic arrest of the heart. In fact, I can mention two standard MCQs here. Every time potassium increases and calcium goes very high, you could be having is a cardiac arrest. If potassium values in a person is more than 8 milliequivalents, then from the one-liner MCQ perspective, you need to remember patient could be going into a diastolic arrest. And if calcium values are in excess of 15 milligram percent, then the person could land up in a possible systolic arrest. Now, with these points in mind, when I go back to the management perspective, if he says, what is the first thing to be done? Your answer would be that I will be initiating hydration in the patient with normal saline. And you can understand that the dilutional aspect to normal saline here will decrease the calcium value. Suppose it is 14.8, then I can downgrade to 14.5 or decrease to 14 by going ahead with the normal saline administration. The next thing that we'll be doing in this patient would be that along with normal saline, we will also add furosemide. And the pharmacological action of furosemide is that it causes calcium loss in the urine. I mean, this particular molecule, it not only causes potassium loss. So you need to be a little wary, because when you will give furosemide, there will also be a concomitant hypokalemia. But at the same time, the benefit at the moment is, the disadvantage is hypokalemia will occur, but the advantage is there would be calcium loss in the urine, which is of advantage to me. So I mean, we are not going to use thiazides, because thiazides reduce urinary excretion of calcium, but furosemide increases the calcium loss in the urine, so it would be benefit for me. The term that we use to describe the combination of the two would be called as a forced diuresis. I'm not talking about acid, forced alkaline diuresis or acidic diuresis of this thing, the word forced diuresis. Next up, I'll explain to you regarding medical management of a patient of hypercalcemic crisis, since I've told you multiple causes that contribute to hypercalcemia, ranging from malignancy to sarcoidosis to rare conditions like Janssen disease or familial hypocalciuric hypercalcemia. Because of the fact that person can die because of development of a systolic arrest of the heart. Like, you know that potassium values, when they will rise, they cause a diastolic arrest. Potassium values in excess of 8 will cause a diastolic arrest. Calcium in excess of 15 milligram percent can cause a systolic arrest. So we need to handle this problem on a war footing. If he says what's the initial management to be done, like for example, the calcium values at the moment are 14.5, whatever. I don't want them to go towards 15, because that's the danger mark. So my initial objective would be to cause dilution in the body by using normal saline. Just like you know that first line management in diabetic ketoacidosis or hypersmolar coma is normal saline administration. Similarly, in hypercalcemic crisis also, the first line management to be administered would be answered by you as hydration with normal saline. Now what I'm going to do subsequently is that to this bottle of normal saline, I'm going to add a loop diuretic as well. The loop diuretic which we shall be using in this case is furosemide, because the mechanism of action of furosemide would be that it will promote calcium loss in the urine. Do not answer thiazides, because you know from pharmacology that thiazides cause a decrease in calcium excretion by the kidney, whereas furosemide would cause a calcium loss in the urine, and which is the reason why this would be preferred. And the technical term that he will use for this would be forced diuresis. Now, the advantage of forced diuresis is that, I mean, the disadvantage is it could be a bit inconvenient for the patient, because he will have to get up and go to the washroom again. The advantage would be a rapid action. So initially, if he just says, what is the first line management for a person with the hypercalcemia or hypercalcemic crisis, then the answer is normal saline and hydration. And then subsequently, we will be adding furosemide to the bottle of normal saline, so that we can ensure is a forced diuresis in the patient. If he says what is the drug of choice for management of hypercalcemic crisis, then your answer would be given as a bisphosphonate. The bisphosphonate that we are going to be using here is zoledronate, or we can be using pamidronate in the patient, which can be given intravenously. Why I'm calling it as a drug of choice is because of the fact that not that it will act very fast. The onset of action takes a while. You see, I was buying time for my patient by using normal saline with furosemide, which will have a rapid onset of action. You see, onset of zoledronate will take at least 24 to 48 hours. Same is the case with pamidronate. The advantage will be that the effect would be occurring. This effect will last for approximately 3 weeks. So I would be, meanwhile, like suppose a person is having a parathyroid adenoma, then we can resect that adenoma. If it is a malignancy, then that malignancy can be handled. But a dose of zoledronate administered at the moment would stabilize the serum calcium over the next 3-week period, where curative therapy or definitive, I'm not saying that lung cancer can be cured permanently, but yeah, whatever is the treatment for lung cancer, whether it's a chemotherapy or a surgical resection, can be planned. Apart from bisphosphonates, what we will also do is give calcitonin nasal spray to the patient. Now, the advantage of calcitonin is that it tends to send calcium into the bones. I would say this is totally opposite of what PTH is doing, and thereby the calcium values in the blood would become relatively lesser. The advantage of calcitonin nasal spray is again rapidity of onset. But the disadvantage is that there is a development of tachyphylaxis, which means that there would be a tolerance developing very soon. As a result of which, I am again not going to call it the drug of choice per se, because yes, it has a rapid onset, but because of tolerance, the effect would not be very, very sustained. Over and above these 4 drugs, additional drugs which can be asked to you and are also used in management of osteoporosis would be a monoclonal antibody by the name of denosumab. Now, how this monoclonal antibody would be acting is that it will be inhibiting osteoclasts which are involved in bone reabsorption, and thereby will tend to stabilize the serum calcium. We would be giving a subcutaneous injection at the moment to make it sound sophisticated, or I can say just to test out your pharmacology, because I said you are going to inhibit osteoclast activation, osteoclast differentiation. He might, write this word bind to rank ligand. Whenever you read this binding to rank ligand, it basically means that you are trying to put brakes on as far as the action of osteoclast and bone destruction is concerned. Binding to rank ligand results in inhibition of osteoclast differentiation. It results in inhibition of osteoclast activation, and thereby will tend to stabilize the serum calcium values in the patient. Point number 6 will not have a very, I would say, fast response, but yeah, this is adjunctive support that we'll be giving to the patient in the form of administration of oral phosphate if the patient can take orally at the moment. Then comes the role of steroids. We can use dexamethasone in our patient. I've already sensitized you to 2 causes of steroid responsive hypercalcemia. I'll repeat those 2 causes once again before you. One of the important causes for steroid responsive hypercalcemia that has already been told to you is having non-caseating granulomas that are going to synthesize vitamin D3 and contribute to enteral reabsorption of calcium and a hypercalcemia. Another cause that I've taught you for steroid responsiveness would be vitamin D intoxication. So I'm going to add data, or I'm going to add to your vocabulary the 3rd reason where you will be using steroids, and that would be related to malignancy. Now, when I say malignancy, the query in your mind would be which malignancy. So you need to remember it would mainly be malignancies which would contribute to development of osteolytic lesions. So here I'm talking about multiple myeloma. I'm talking about leukemia. Yes, hematological malignancies are to be answered here first. That would be multiple myeloma, leukemias, then lymphomas. And then your answer would be one of the cancers which was contributing to hypercalcemia, that is breast cancer. But in this list, lung cancer is not there. For lung cancer, squamous cell cancer, surgery would be required. Otherwise, it can cavitate, it can exhibit a local spread, pressing on the trachea, it can contribute, or the bronchus, it can contribute to multiple problems ranging from segmental collapse to development of stridor in a patient. The message is hematological malignancies like multiple myeloma, osteolytic lesions, leukemias, carcinoma breast, sarcoidosis, and vitamin D3 intoxication. They are situations where you shall be using steroids. Dexamethasone can be used. And then over and above this, another, I would say, trump card that I have at my disposal to handle our patients of dangerous hypercalcemia would be dialysis. Now, when it comes to this dialysis component, what we can do is we can be doing is a peritoneal dialysis in a patient. Let's look at, how peritoneal dialysis will be effective is because peritoneal cavity has a big surface area. So what we do in this case is that the dialysate fluid that we use is calcium free. Repeat once again. Normally dialysate fluid would be having some concentration of calcium. Here we are using is a calcium free dialysate fluid for performing peritoneal dialysis, and because peritoneal cavity has a big surface area, so we could be losing calcium and thereby stabilizing the serum calcium of our patient. When would you be using this dialysis? This would be a last resort. Like I said, it's a trump card that you'll be using. So he says that this is mainly, this can immediately reverse life-threatening hypercalcemia. So if the values are spiking near 15, I'll obviously start hydration, I'll obviously start using drugs. But then the point is that the drugs will obviously take their time to act and cause loss of calcium via the urine. So I want to lose it via the peritoneal cavity. So immediately, the drug will act, the process of calcium-free dialysate helping in loss of calcium will act immediately and would be recommended for patients with life-threatening hypercalcemia. So if he gives you calcium values outrageously high, like 15, like in the exam he has given mild. If it is a mild case, no issues, like a value of 11 to 12, you can easily manage the patient with the bisphosphonates. Obviously, if renal failure is there, bisphosphonate dose needs to be adjusted, but otherwise you can manage the patient with hydration, furosemide, bisphosphonate, and if it is like multiple myeloma contributing to it, you might have to add steroids also. But my point is, if a person is having renal failure, suppose he is already in end stage renal disease, like due to multiple myeloma only, then in those cases peritoneal dialysis would be useful because it will help you stabilize the kidney parameters as well. And if he gives you outrageously high values of calcium ranging up to 15, then dialysis is to be answered. Otherwise, your routine answers would be the way that I've mentioned. If he asks you to select one, then though the textbook does not mention the word drug of choice per se, but I can say that a drug that will stabilize over the next 24 to 48 hours and will maintain that by the time you handle the cause. He says treatment of hypercalcemia is treat the cause, whichever is responsible for it. But if you want to keep the patient in a stabilized state, even to make him fit for surgery, you will have to use bisphosphonate in the patient in an intravenous format. Now the subsequent topic that I'll explain to you is much more simpler and straightforward to comprehend, where we'll talk about secondary hyperparathyroidism, which is caused by CKD. One of the leading reasons why in India you could be having a CKD is because of diabetes contributing to diabetic nephropathy. And since the person did not take his medications, he's had a chronic kidney disease. Kidney is the site of synthesis of vitamin D3. You see in the proximal tubules of the kidney, we have 1-alpha hydroxylase, which produces the active form of vitamin D, that is 1,25 dihydroxycholecalciferol. In patients who are suffering from CKD, what's going to ultimately happen is that synthesis of vitamin D3 would be less. This is going to contribute to less calcium, and less calcium is the trigger which will contribute to increase in the value of PTH. So because I wrote so many physiological facts, like there is less synthesis of vitamin D3, so there is less calcium, which is triggering a release of PTH. So the term that I'm using here is secondary hyperparathyroidism. In these particular patients, one of the important things that I want you to remember is that there are two ways to understand what I'm saying right now. One, I told you calcium and phosphate have an inverse relation. If calcium is going to be less, then phosphate is going to be elevated. Or another way to understand why phosphate would be elevated in CKD patients, and that's itself a kidney question. Why do you have hyperphosphatemia in a CKD? Is because of low GFR, because phosphate is not getting excreted in these patients. So the values I wanted to remember is calcium is going to be low. It's going to trigger release of PTH. And the bad news is this PTH will then cause a bone reabsorption. And therefore it can cause weakening of the bones like ribs, clavicle, vertebra, and therefore pathological fractures can develop in these patients. So as such, in patients of CKD, you could be having is a development of bone pain, and you could be having is development of even a pathological fracture. Why? Because kidney was affected, that resulted in lower synthesis of vitamin D3, low calcium, and an elevated PTH contributes to bone damage in the patient. If I use a single word to describe all of this, then the textbook will use the term azotemic because it started from the kidney. Osteodystrophy because ultimately bones would be involved. Osteitis cystica fibrosa can be seen with both primary and secondary hyperparathyroidism. Don't be under impression that osteitis cystica fibrosa / brown tumor that you study in pathology is seen only with primary. It can be seen with secondary hyperparathyroidism as well. Though the values here are written, still for the sake of completion, I'm writing when I am going to do a workup in this CKD patient, this is what I'm going to encounter. Calcium is going to be less, phosphate is going to be elevated because it is not getting excreted, bone turnover is enhanced in hyperparathyroidism, so SAP is high. In these patients, when I check out the PTH values, it would be elevated, And along with this, when I do serum vitamin D3 levels, the values of serum vitamin D3, because synthesis is hampered, would be relatively less. Plus, I can check out the eGFR of the patient by online calculators, like I can use Cochrane Gold formula, or I could be using his MDRD formula. So estimated GFR in the patient would be less. I can also check for urinary albumin creatinine ratio, and because his kidney is damaged by diabetes, therefore urinary albumin would be increased. I mean, formerly we used the term microalbuminuria, but now we just use the term urinary albumin creatinine ratio. That would be in excess of 30 milligram going up to 300 milligram per gram of urinary creatinine. Along with this, if I have a KFT report, serum creatinine in the patient would be affected along with electrolytes as well. And because every time kidney is damaged, potassium would be elevated. And then once we have all these derangements present, let's look at what we can do for management of a person of secondary hyperparathyroidism. Ideal is obviously a renal replacement therapy or kidney transplantation, but that may not be feasible all the time. So what I'm going to do in this patient is I'm going to give calcium, and I'm going to give vitamin D supplements to this particular patient, that is calcitriol. But the problem is that PTH is still high and it would be causing bone reabsorption, and the damage to bones can even cause pathological fractures. So the examiner not only wants to hear about calcium and vitamin D3 supplementation in this case, but he also wants to read about this drug, which is the calcimimetic drug. This calcimimetic drug stimulates the CASR, the calcium sensitive receptor of the parathyroid gland, and makes it believe that okay, calcium is there. This behaves, I said this is a cinacalcet. Let me just write down the name, cinacalcet. This is a calcimimetic drug. It behaves like calcium. When I say it behaves like calcium, this particular drug will stimulate CASR and will tell the parathyroid gland, oh, calcium has come, and parathyroid gland will shut down its excess PTH production. And when you shut down the excess PTH production, you are preventing the further bone reabsorption occurring in this patient and negating or reduces the chances of development of, you will prevent the progression of bone pain, and you will also prevent the development of any unfortunate scenario of a pathological fracture in these patients as well. Next up, we'll talk about hypoparathyroidism, where PTH values would be lesser. So let's first summarize the causes why PTH would be lesser. The first reason why there is a decreased PTH production is due to autoimmunity. And the first time I taught you autoimmunity was for type 1 diabetes, then for 1.5 diabetes, and then also I have blamed autoimmunity for as being a reason behind development of Graves' disease, then Hashimoto's. So in endocrinology, this autoimmunity, and even in Addison's disease, autoimmunity has been blamed. Now, usually we could be having is either autoimmunity written in the MCQ, or he may deliberately write this term, autoimmune polyglandular syndrome, which tells you the fact that not only the patient's PTH or parathyroid gland is affected or PTH production is hampered, but simultaneously in the patient, the thyroid gland can be affected simultaneously in these patients. I mean, multiple endocrine glands can get involved here. Just like you're aware of men where multiple endocrine glands can develop a tumor, here I'm saying multiple endocrine glands can be affected simultaneously. So you could be having is a combo of Addison's disease and hypoparathyroidism developing in a patient. Like I'm teaching at the moment, autoimmune polyglandular syndrome type 1. In this condition, you could be having is a concomitant Addison disease manifestations in a person as well. Because genetics is the in thing nowadays. So autoimmune polyglandular syndrome, chromosome 21 defect, the gene which is defective here is IR gene. And I have covered the topic of autoimmune polyglandular syndrome towards the end of the video of multiple endocrine neoplasia. Over and above this, the third cause which should be remembered is that this would be a post-operative surgical patient. Let me say he was having a papillary cancer of thyroid and he underwent a total thyroidectomy. So post-operatively, when we are evaluating a patient who's undergone a total thyroidectomy, there could be an inadvertent removal. Mark my words there. I said there was an inadvertent removal of the parathyroid glands, and that would explain why the calcium values in this patient would be lesser. Though you are aware from your surgery classes that the chances of development of this would be relatively lesser nowadays, because the surgeon would be performing is a parathyroid reimplantation. The site for parathyroid reimplantation has been asked in the exam multiple times. You would be aware there are two sites. Either we can put it in sternocleidomastoid or we can put it in brachioradialis. If they ask you to select one side, the preferred one would be brachioradialis for a parathread reimplantation. So if this procedure has been done, then the chances of manifestations of hypoparathyroidism would not be occurring in a patient. But let me say the patient is operated in a center where this was not done per se, then this person will develop post-surgery hypoparathyroidism. Then he can incorporate a pediatric cause as well, that is Dye-George syndrome. This would be a disease with respect to problem in chromosome 22 and defect related to the third and the fourth brachial arches. And as a result of which, not only the development of thymus will be defective, but the development of parathyroid in this case is also defective. Now, because there is a defective thymus development, so I can say that this child from a young age will be having repeated infections because the cell-mediated immunity is reduced, and because the parathyroid gland is also not working. As a result of this, these patients would be having is less PTH, and therefore hypocalcemia will occur. And in a child, if there is a hypocalcemia, then his height will not increase. There would be delayed dentition in a patient. So I am not using the word rickets, but I can say rickets-like illness could be developing in a patient. There are 4 causes for development of hypoparathyroidism that are described. 2 of them are having autoimmunity coming up. Then could be a surgical one and Dye-George syndrome. And we'll next discuss regarding what would be the clinical presentation in the patient. The clinical presentation can be divided into 2 parts, that is acute hypocalcemia versus a chronic presentation. I'll first handle acute hypocalcemia because of the risk to life or threat to life, because if calcium values go less than 7, then tetany can be a manifestation. Like for example, after a thyroid surgery, usually by the 2nd or the 3rd day, manifestations of tetany can occur in a patient. I'll create a case-based scenario which will make it more in sync with the current pattern of the exam. The case that I'm describing here before you is of a patient who has, let me say, undergone a total thyroidectomy. You are the intern in the surgical unit, and on day 3, you are seeing a patient or examining a patient who's undergone a total thyroidectomy. Now, there's a possibility that your nurse initially went to talk to the patient, and when she was talking to the patient complained that he is having tingling sensation around his lips and around his fingertips, and your nurse could not make much out of this clinical presentation. So she said, "Doctor, can you just have a look?" Because in surgery unit, no, half the time you will be doing dressing of the patient, or you'll be putting cannulas, or you'll be putting tubes. So the point is, it could be NG tube or a chest tube. The point is, after all, you'll be busy with so many things that usually interaction in a post-operative scenario with the patient is very limited for an intern. And here you are having a nurse who's requesting you that please have a look at the patient who's having this peculiar complaint of tingling sensation around his lips and fingertips. So, in fact, this is itself a question. What is the earliest clinical manifestation of tetany? That would be perioral and periangual paresthesias. And what I'm going to do in this gentleman is that I'm going to deploy a BP cuff in his arm. I will deploy this BP cuff at 20 millimeter above the systolic blood pressure. And if I do this activity in you and me and keep it there for 3 minutes, all it will cause is a discomfort. But in these patients, you will notice that you will be able to elicit irritability. Hypocalcemia causes nerves to become irritable. So you would be able to, I would say, cause irritability of the median nerve. And due to this irritability of the median nerve, I'll cease writing for a minute and just focus on my hand. You will notice that in the arm where you put the BP cuff, the thumb of the patient will be showing an adductor spasm. The thumb will be showing an adductor spasm. So the manifestation is written in the book as development of carpopedal spasm. This is one of the reasons why these patients, because I said neuromuscular excitability is increased in hypocalcemia. So this patient is potentially at risk from dying, because even in these patients, laryngospasm can develop, like related to the nerves of the vocal cord. Again, irritability, vagus nerve supply is here. So that can contribute to laryngospasm and the person can die. Like in anaphylaxis, you have laryngeal edema. Tetany can kill a person due to development of laryngospasm. And first, I'm trying to check out the nerve irritability by demonstrating carpopedal spasm in this patient. Another way to describe this would be the position of the hand with the way I showed it. This could be written in MCQ also as obstetrician's hand. Now, the technical term that is used to describe everything that I have written currently on the board before you or on the slide before you is called as Trossius sign, which is one of the features of symptomatic hypocalcemia. The next what I'll do in the same patient would be that I'll be doing tapping on the anterior border of the parotid gland. Coming out of the anterior border of the parotid would be the facial nerve. I am trying to irritate or demonstrate the facial nerve irritability, and in normal person, if you tap on the anterior border of the facial nerve, it will not contribute to anything. But in this person, you will be able to elicit a facial nerve irritability, which will contribute to development of twitching of muscles around the lips. You would be getting is circumoral twitching. These two terms that I've said here before you, circumoral twitching and then the carpopedal spasm. The terms, the signs which are very classical ones to be remembered here are Trossius sign and Chvostek sign. Most of the time in the exam, he will try to either mention regarding the names of these signs, and especially while answering Trossius sign, be careful that he could be asking you Trossius sign from the surgery perspective. You see, a Trossius sign is also seen with respect to, the manifestation that I'm writing is what you read in surgery, that is migratory superficial thrombophlebitis. When I say migratory superficial thrombophlebitis, then this would be associated with cancers like lung cancer, for example, is associated with Trossius sign, or even pancreatic cancer can be, or stomach cancer can be associated with Trossius sign per se. So Trossius sign is written in medicine for median nerve irritability, carpopedal spasm, but in surgery you read about this in association with malignancies as well. And tetany is anyway a medical emergency in a sense that if you do not intervene at this point of time, then the chances of development of stridor and chances of development of laryngospasm in the patient is very high. In fact, I can just jot this point here only, that do not answer laryngeal edema, which is to be answered for a patient who's having anaphylactic shock. Laryngospasm is one of the reasons why these patients can expire. Now, coming to workup of a patient of acute hypocalcemia, one of the baseline investigations that must be done is ECG. Why? Because you see, when you will take the blood sample of this patient and send it to the lab for calcium and ionized calcium values, it will take a while for the laboratory to turn around and give you a report. So in the intervening period, before I get the report from the laboratory, I can be doing is a ECG, and what you will find in the ECG of this patient would be that the QT interval will be showing is a prolongation. Yes guys, this is an often neglected point. Calcium in the blood is inversely related to the QT interval in the ECG. In most questions of hypocalcemia or hypercalcemia, QT word or QT interval duration will be mentioned. As I told you, inverse relation. So in tetany, because calcium is less, QT interval will always be prolonged. Normal is 9 to 11 small squares, that is 360 to 440 milliseconds. I have sent the sample to the laboratory for total calcium values and ionized calcium values to be checked separately, because ionized calcium in the body is bound to albumin. So we will get this also checked. When the report came, the albumin values were normal, but the total calcium values and ionized calcium values were reduced, and mainly in tetany it is the ionized calcium value which is of primary concern, which would be lesser in the patient. At this moment, I can say do not mix it with tetanus, where we have is again a laryngospasm, but then tetanospasmin is the toxin in tetanus which contributes to manifestations. Here it is irritability of the neuromuscular system which is contributing to problems in the patient. For the treatment of these patients, IV 10% calcium gluconate will be given to the patient. That will help in tiding over the initial crisis, but this is not a permanent solution, because in any patient who's having surgically induced hypoparathyroidism, I told you, you can easily prevent it by going in for parathyroid reimplantation, but that was never done in the patient. So now the person would have to be exposed to, or rather administered, injections of teriparatide, which would be manufactured, which would be like I can say artificial PTH manufactured in the lab by DNA recombinant technology. So for surgically induced hypoparathyroidism, I repeat once again, for surgically induced hypoparathyroidism, teriparatide is the drug of choice. Otherwise, if he says first line management for symptomatic hypocalcemia, or what is the treatment for tetany, first line management for tetany is calcium gluconate. But this is not going to be a permanent solution, so you need to find a solution in the form of teriparatide injections for the patient. We shall now talk about manifestations of chronic hypocalcemia that could be occurring in a patient with hypoparathyroidism. When it comes to less calcium in pediatric age group, everybody is comfortable with features of rickets, but I'm going to describe to you manifestations of chronic hypocalcemia in an adult, and that would be in the form of a basal ganglia calcification. The moment I write this, the query that I get in a live class and obviously in the one that you are listening to at the moment, I mean, I get a lot of messages, sir, how is it possible? On one hand, you are saying calcification, and on the other hand, you are saying there is less calcium. Well, one, I can justify this by saying that where did all the calcium go? It got deposited in the basal ganglia, so it is less in the blood. But then how or why did it get deposited? First and foremost, you remember, I told you this basic rule, calcium and phosphate have an inverse relation. So in any patient who's having hypoparathyroidism, which is the main topic that we're studying due to autoimmunity, calcium will be less, that is understandable. But phosphate will be elevated, and it is this elevated phosphate which is contributing to development of deposition of calcium phosphate in the tissues. I'm telling you a mathematical rule that if calcium phosphate multiplication product in the body crosses more than 55, listen to this carefully. If calcium or phosphate multiplication product in the body becomes more than 55, the two will chelate and will get deposited in the tissues. So it does not matter that only calcium is elevated. Like if calcium is elevated, multiplication product more than 55, deposition of calcium phosphate in tissues. But there could be a possibility calcium is less, agreed, but phosphate can be disproportionately elevated. And because of this disproportionate elevation of phosphate, once this mathematical threshold is exceeded, it would explain this basal ganglia calcification. You do not need to get into, I am erasing this because I just had to explain this to you that this is what we have demonstrated. Ultimately, what happens in the patient is whether calcium, whether phosphate, either of the two increase will contribute to calcium phosphate getting deposited. So in persons of hypoparathyroidism, it is phosphate rise which is explaining this basal ganglia calcification. And as a result of this, the features in the patient would be of extrapyramidal, that is dystonia, or you could be having is oculogyric crisis. Oculogyric crisis would mean that person's neck would be turned to one side, eyes deviated maybe to the contralateral side, and along with this, if it is, let me say, damage to the subthalamic nucleus because of the calcium deposition, then you could be having very classical manifestations like hemiplegismus as well. The calcium phosphate, the disproportionate phosphate will chelate with whatever less calcium is present. And in fact, calcium is lots in the body in a sense that it comes from the bone. So the two can chelate and can cause ocular cataracts in the patient. Any patient having less calcium, problems with dentition will be present. So I've written abnormal dentition and a dry skin. Mostly in the exam, you need to remember regarding basal ganglia calcification as a presentation of hypoparathyroidism. Basal ganglia calcification can be seen even with hyper. I did not write it. I am telling you at the moment, can be seen with hyper, but mainly it is basal ganglia calcification is seen more commonly with hypoparathyroidism. And because of the fact that a person might be having autoimmune polyglandular syndrome. I'll just change the slide. I had told you this, that reason for hypoparathyroidism could be autoimmune polyglandular syndrome, where there could be concomitant development of damage to the adrenal gland as well. So no big deal that these patients, apart from hypocalcemia, could be having salt wasting, salt craving. There could be postural hypotension. The reason for postural hypertension is salt and water getting lost from the body. So features of Addison disease may or may not be present in a patient. Along with this, even candida can be developing. These features that I've written as plus minus before you, they would be encountered in those patients who are suffering from autoimmune polyglandular syndrome. I'll have to mention it, though it is mentioned autoimmune polyglandular syndrome is discussed separately with multiple endocrine neoplasia towards the end. Autoimmune polyglandular syndrome type 1 could be associated with any of these two manifestations. Because it is rare, I have repeated this, and from the exam perspective should be remembered. On the basis of this information, I think you would now be comfortable remembering workup of a patient who's having hypoparathyroidism. I have deliberately divided the discussion into two parts: acute hypocalcemia and a chronic hypocalcemia. When I'm going to check out the calcium values, phosphate values, and the serum alkaline phosphatase, calcium will be less, understandably, because PTH is less, and calcium phosphate have an inverse relation. Or you can remember that PTH was responsible for causing loss of phosphate by the kidney. Now that loss would not happen, so phosphate is elevated. But make no mistake, if he says what happens to serum alkaline phosphatase in the patient, the answer is normal. If you're listening to me carefully, I had told you that in hypoparathyroidism, you do not have a decrease. The decrease of serum alkaline phosphatase is seen with hypophosphatasia. The very first or second slide that I've explained here, hypophosphatasia causes decrease in serum alkaline phosphatase. In hypoparathyroidism, the value is normal. The additional test that I can do in this patient is a second or a third generation serum PTH assay. And since the values would be very less, if it is autoimmune, if autoimmunity is destroyed at early part of the disease, it would be less, later part would be undetectable. So when you get the report, kind of report that I mentioned with the undetectable PTH, then for these patients, we do not have a treatment of choice. Obviously, I will give calcium, I will give vitamin D, but teriparatide is mainly recommended only for surgically. I'm having to write that again. Only for surgically induced hypoparathyroidism is teriparatide FDA approved, and if it is autoimmune destruction, it is symptomatic management. I mean, I will give calcium, I will give vitamin D3 to the patient, but there's no drug of choice per se for an autoimmune mediated hypoparathyroidism in a patient. We shall be now comparing hypoparathyroidism with a disorder that is called as pseudo hypoparathyroidism. Look at the surprising thing that I tell you here. The problem in this particular patient is not at the level of the hormone, but it is rather a problem in the receptor. Just like in type 2 diabetes, we have is the receptor resistance. Similarly, in pseudo hypoparathyroidism, the resistance is at the level of the receptor. And by feedback mechanism, what will happen is that PTH values will rise. I would like to remind you that in type 2 diabetes, we have a resistance to the insulin receptor. So by feedback mechanism, I mean, that's a basic rule of endocrinology. If the receptor misbehaves, you have the primary hormone values getting increased. So in type 2 diabetes, insulin values are elevated, but the receptors are misbehaving. There's a receptor resistance in this case. Or I can write in a different way that there will be a reduced responsiveness to PTH in the kidney. I had told you that the main function of PTH in the body was, or PTH with respect to the kidneys, it will act both on the proximal tubule and distal tubule. When I say reduce responsiveness to PTH in the kidney, then two things will happen in the patient. Let's look at it from the perspective of first the distal tubule. In the distal tubule, the absorption of calcium will be lesser. I'm just going to write it theoretically so that you can remember the impact that happens. I mean, why am I saying that in this patient calcium will be less is that if PTH will not, PTH is the driver which forces, that's the very first few lines of this video. I said PTH is the driver that forces calcium reabsorption by the distal tubule of the kidney. If you are having a resistance to the action of PTH, if it's not allowed to act, then there would be less reabsorption of calcium, which will explain that why do you get hypocalcemia in these patients. At the same time, the response of the PTH will also be less. There will be less excretion of phosphate. I told you that normally the main function of PTH is that it causes loss of phosphate by the proximal tubule. Now there will be less excretion of phosphate, as a result of which the phosphate values in the blood would be elevated. If I'm going to do a workup of this patient, the calcium will be less, phosphate will be elevated. The reasons I'll repeat once again. Why calcium is less is because the reabsorption that is supposed to occur by the kidney is lesser, and phosphate that is supposed to be kicked out is not happening. The values of SAP in this patient will turn out to be normal. And if you focus on this particular report, the one that I have marked out in green, I'll just mark out the report once again. Less calcium, more phosphate, and SAP is normal. The same report which I've highlighted here was even discussed on the previous slide. I'm swapping the slide, guys. The same report was discussed even for hypoparathyroidism. The blood report in hypo and pseudo hypoparathyroidism is same. Look at this once again. This report that I told you is for hypoparathyroidism, and compare this report with the one that I told you once again for pseudo hypoparathyroidism. I mean, that's why we're calling it pseudo, no, because there is a reduced responsiveness to the action of PTH. The main issue is the report is same, but you can still make a difference from the value of PTH. You see, this blood report that I am marking once again, this blood report is same as that of hypoparathyroidism. But the difference is in hypoparathyroidism, PTH is lesser. Here I am telling you PTH is elevated. Why? Because the receptor in the patient is misbehaving. The question that would be coming to your mind at the moment is that why is this happening, sir? I mean, why is the receptor misbehaving? So what we have demonstrated is that there's a defect on chromosome number 20. There's a special genetic locus, that is GNAS locus, which is gonna be the troublemaker here and contribute to developing a pseudo hypoparathyroidism in a patient. The peculiarity from the genetics perspective is that this particular disease causes a defect in PTH action, and it is inherited always from the maternal side. I hope all of you remember genomic imprinting in pathology. Like you read Prader-Willi P comes from paternal side and Angelman syndrome comes from the mother side. Similarly, here I'm telling you that in this particular disorder, due to this genetic reasons, there is inactivating GPCR. GPCR is G protein coupled receptor. That's the that's how PTH acts. When you study physiology, the PTH will be acting by G protein coupled receptor, and in this case what is happening is this receptor is misbehaving. So I'm writing inactivating GPCR mutation. So PTH is there, but it is not able to act. The peculiarity of pseudo hypoparathyroidism is that it is inherited from the maternal side. So over and above Angelman syndrome, I wanted to remember pseudo hypoparathyroidism is also inherited from the maternal side. Let's look at what will be the clinical features which will be present in this patient, and leave a line on the top for, if you're noting with me, just leave a line on the top for the the summary of the clinical findings. You will notice that since this condition is genetically acquired, right from childhood, serum calcium values are lesser, so the child's height will not increase and he will be having is a short stature. Mostly short stature children tend to put on weight, so they would be concomitant obesity. And then you will read this term because their metacarpal bones and their metatarsal bones will be shorter. So you will read the term brachydactyly. Brachydactyly means short metacarpal bones as well as metatarsal bones. These patients would also be having is a low IQ. And for the short metacarpal bones, I can put it like this. If you can look at my hand, you see if I form a wrist, you can form a wrist in your own hand. You can feel your knuckles, no? You can feel these four knuckles, which are the metacarpal heads primarily. Now what happens in these patients is that most of the time the fourth and the fifth metacarpal bone is relatively shorter. Because the fourth and the fifth metacarpal bone is shorter, so there is a possibility that instead of feeling a knuckle here, you may be able to feel a dimple. What I'm telling you at the moment, it will sound very, peculiar if you're reading it for the first time. What I'm telling you at the moment is called as knuckle, dimple sign. When we read it the first time, it looks a little peculiar. What is knuckle, dimple sign? So I'll repeat it once again. What it basically means is that you are having in the patient, due to less calcium, there is shorter bones, metacarpal bones. So you have is short fourth as well as the short fifth metacarpal bones. The longest name for this is knuckle, dimple. The shorter term that they use for this is called as Archibald sign. So you can differentiate this condition easily from nutritional rickets, because in nutritional rickets also a child would be having short stature and the weight may be a little on the higher side or a chubby kid, but you would not be having this knuckle, dimple sign. The term that they use in the textbook for this condition, since this is genetically acquired and comes from the mother's side, is Albright hereditary osteodystrophy. So for pseudo hypoparathyroidism, first and the foremost thing that you need to remember is that these patients would be having a report which is same as that of hypoparathyroidism. When you read through the question, it may be a longish question with clinical domain and clinical features you may not be even remembering also. What you need to check out in the question is calcium is less That's the entire game of calcium metabolism or calcium metabolism based questions. Calcium is less, phosphate is elevated. Inverse the relation. It could be kidney involvement also. But if it was CKD, in CKD, serum alkaline phosphatase, when I can just go back to that slide, when we were discussing a patient who's having a secondary hyperparathyroidism, the reason for elevation of phosphate was different. It was low GFR. And serum alkaline phosphatase in the patient was elevated. But I'll just minimize this. You can see secondary hyperparathyroidism, calcium phosphate, less, calcium is less, phosphate is more, SAP was elevated. But in hypoparathyroidism, what happened was that there was less calcium, there was a elevated value of phosphate in the patient, and simultaneously, I'll just show that slide so that you remember it. For patients who are having hypoparathyroidism, you can see here the report is different. The SAP values are normal, and in the end, I'll make a table. I'll hand draw a table before you where we will try to remember this information, because at the moment in endocrine, guys, this increase decrease is the main thing that you need to go through. So what's happening in this case of pseudo hypoparathyroidism is that the report is same as that of hypoparathyroidism, but the PTH values in the patient are elevated, and the clinical profile of the patient would be called as Albright hereditary osteodystrophy. There is no definitive treatment for this condition. If he wants to trouble you further, he can come out with another disease. I'll take a long time to write it. I mean, look at the number of alphabets that I'm having to write. This is a variant of pseudo hypoparathyroidism, which is called as pseudo. The pseudo word is coming up 2 times. So now I'm teaching you a disorder where look at, I mean, it's occupying almost whole of the slide. Just the name of the disease itself. I'm going to describe to you a variant of pseudo hypoparathyroidism, which is called as pseudo hypoparathyroidism. The highlight of this, the P alphabet is coming 2 times. The highlight of this pseudo hypoparathyroidism is one, that this is always inherited from the paternal side. Like I was telling you that in PHP, pseudo hypoparathyroidism, the inheritance comes always from the mother side. In pseudo, genetic studies have shown inheritance from the paternal side. Even in, why do they call it pseudo twice, is because in this condition, the AHO, Albright hereditary osteodystrophy that I described, short stature, knuckle, dimple sign, that same thing is also present. But if you are going to check out in this patient the value of calcium, value of phosphate, whether you check out the value of PTH in these patients, all of these values would be perfectly normal. And when I say everything is normal, the query most people is, sir, what disease are we talking about? Everything is normal. Then you're saying there is a disease. Yes, guys, this is a genetically acquired disease where the action of PTH on the bones is defective. Because the action on the bones is defective, that is why you're having that short stature and Albright hereditary osteodystrophy. But action on the kidney is normal, because this is a very peculiar disorder, and the only disorder where you will read that on one tissue in the body, action of the hormone is normal. In other tissue, the action is abnormal. Traditionally, what happens is if one hormone is less, then action on all tissues would be defective. Here, what is happening is action on one tissue is normal. The action on the second tissue is normal. The action on the bone is defective. So we have is AHO, but the action on the kidney part is normal. So calcium phosphate per se is normal. The PTH values are also normal. The disease is called as pseudo hypoparathyroidism, and there is no treatment for it. And I know that because of the data that I have created here before you, you'll be saying, sir, how to remember all this? So jot down these words before me. Don't be lazy. I know you printed notes. What you're going to do is jot down these 3 names: hypoparathyroidism, pseudo hypoparathyroidism, and then pseudo hypoparathyroidism, and make a quick table with me. First and the foremost is hormone related issues. In hypoparathyroidism, PTH values are lesser. In pseudo hypoparathyroidism, because the problem is of the receptor, so PTH values are elevated. Just like in type 2 diabetes, the receptor is defective, insulin is more. Here, PTH receptor is defective, so PTH is more. And in pseudo hypoparathyroidism, PTH values are normal. Now, in patients who are having hypoparathyroidism, why is it happening? Your answer is autoimmunity. When it comes to pseudo hypoparathyroidism, the disease is genetically acquired. Defect is on chromosome number 20, but it is always going to be having a peculiar maternal inheritance. When it comes to pseudo hypoparathyroidism, it will always be having a paternal in fact the two P's are coming up now, so P can be, because emphasis of P word is there, father's side, paternal side, so the peculiarity here is paternal inheritance. In both of them, that is PHP and PPHP, in both of them the chromosome that is involved is still chromosome number 20 only. It is still related to the genus locus that I'm talking about, and the inactivating mutation related to GPCR, and the clinical manifestation of both of these diseases, that is PHP. Why they write it as double PHP is because it is looking like PHP only. It is having same clinical manifestation, that is Albright hereditary osteodystrophy. But how would you differentiate these two patients? I mean, how would you know that a short stature kid with that knuckle dimple sign, is he PHP or is he PPHP? One way to differentiate is check out the values of PTH. And apart from the values of PTH, what you can also do is, and that is the exercise that I want you to do, is that in patients who are having PHP, phosphate would be elevated. But phosphate values will be normal in patients who are having PPHP. In fact, that phosphate thing I've written with a separate color at the moment because there's a possibility you may not remember it, but that hormonal issues has to be clear. Autoimmune destruction of the gland primarily for hypoparathyroidism. And what is the clinical manifestation of hypoparathyroidism? In adults, the chronic hypocalcemia manifestation would come up. So the person would be having is a development of basal ganglia calcification. Now the scope is open, field is open for examiner. He'll throw in words of extrapyramidal, dystonia, hemiparesis, oculogaric crisis, and he will then talk about cataract. He will talk about dry skin in this patient, defective dentition in the patient. So whenever you are having hypoparathyroidism, gradual destruction, these are the manifestations in an adult patient. PHP and PPHP will mostly be kids, and there would be features of AHO given, knuckle dimple sign would be given. If you find inheritance given, great. Otherwise, hormone issues would help you. If not hormone issues, then it is going to be phosphate values that would come to your aid. At least remember, for PHP, phosphate values are elevated. The report of HP and PHP would be identical. Now, let's do this activity once again so that this becomes a permanent memory for you. So, if you were lazy initially and did not listen to me to note down, and you are just looking at the printed notes, try to do this with me, because in calcium metabolism, the main game is what I'm doing right now. In about a minute, in a multiple choice question, you should be able to work out from the report, or you should be able to work out the lab report for each one of them with respect to calcium, phosphate, and serum alkaline phosphatase. Let's do this activity, guys. Make a quick 4x3 table. Now, in patients who are having primary hyperparathyroidism, we discussed there was an adenoma, which was the mischief maker. It was causing increase in the values of calcium. Bone reabsorption is increased by distal tubule also. There would be increased reabsorption of calcium. Calcium phosphate go a inverse relation. This time I'm not going to logic, I'll say they'll go into inverse relation because I have limited time in a multiple choice question, and bone turnover is more, so SAP would be elevated. The management of these patients would mainly be surgical resection of the adenoma. But if I need to do medical stabilization first, I will be using normal saline. I'll add furosemide. I will use bisphosphonates. If the condition is amenable to steroids, then steroid response. If it is steroid responsive hypercalcemia cause, then I'll be using steroids in the patient as well. Though obviously, I mean, if it's an adenoma, then there is no point of administering steroids in the patient. For secondary hyperparathyroidism, remember the cause is a defective kidney. The kidney is not synthesizing vitamin D, so calcium will be less. Calcium and phosphate have a inverse relation, and bone turnover will once again be increased in the patient. I'll be using calcium, vitamin D3 and cinacalcet in these patients. If he talks about hypoparathyroidism, then for hypoparathyroidism, you need to remember that calcium will be less, phosphate would be elevated, but SAP values are normal. For hypoparathyroidism, there are two etiologies that I've described before you. One would be autoimmunity, the autoimmune destruction of the gland, or autoimmunity with polyglandular syndrome. Or it could be a surgery as well. I'm just writing SX. What I mean by surgery here is the person underwent a total thyroidectomy, and along with that, parathyroid gland was also resected. And for the surgical variety, I had told you that we have a drug available that is by the name of teriparatide. When it comes to pseudo hypoparathyroidism, you don't need to use too much of your brain. The report of this patient will be same as that of a patient of hypoparathyroidism. The only difference will be that if a person is having hypoparathyroidism, then PTH will be less because autoimmune destruction of the gland was occurring. But here the problem is of the receptor, so PTH values would be elevated in the patient. PHP comes from mother side, PPHP always comes from the paternal side, and in PPHP anyway, everything is normal. It is mainly a AHO presentation. There is no treatments available, so don't bother about the treatment part for these. But if you can get this table right, the one that I mentioned, the comparisons that I mentioned, then you are on your way to solving these questions of calcium metabolism, where these values would be given and you would be asked to interpret them. Now, to finish this topic, in the last, I would like to mention regarding nutritional rickets that you read in pediatrics. I mean, have a good listening to that from the pediatrics part of the app also. But what happens in nutritional rickets is that vitamin D3 is less. Please follow the arrows. Vitamin D3 is less, so calcium would be less. And because calcium is less, PTH would be increased, because every time calcium is less, PTH has to increase. What does PTH do? PTH causes phosphate loss. And therefore, you will notice that for the first time in this discussion, I have told you that calcium and phosphate are going in same direction. You see, in all the conditions that I was discussing from the general medicine perspective, calcium and phosphate were having an inverse relation. But from the pediatric domain, the moment I introduced nutritional rickets, I told you calcium and phosphate was going in the same direction. And here, why phosphate is going down is because the GFR of the patient is perfectly normal. You see, when the kidney was involved, like in a person who was having secondary hyperparathyroidism, calcium was less, but phosphate was getting elevated because phosphate is not getting excreted due to defective GFR. Here, GFR is perfectly normal, so the kidney can lose phosphate, and that's the reason why calcium and phosphate will go in the same direction and SAP values would be increased. So when you read a pediatric question that talks about craniotips, etc., fine, I know you will pick up rickets, but remember that the arrows with respect to nutritional rickets for calcium and phosphate will be going in the same direction. I mean, nobody has an issue with calcium. The main issue is with phosphate. Why is it lesser? Because there's a normal GFR and the PTH can act. Whereas if it's a kidney issue in a person, then action would not happen. Also, I would like to remind you that when it comes to a case of osteoporosis, the values of calcium, phosphate, and serum alkaline phosphatase all would be perfectly normal. So as such, when you want to diagnose osteoporosis in a patient or to determine the bone densitometry, you'll be doing a DEXA scan in the patient. The report of the DEXA scan will be giving you a T score as well as a Z score. If he says which of the following scores will be used to monitor response to treatment, then remember treatment begins with the word T. Treatment begins with the word T. Though in the report it will be written T score less than -2 standard deviation, Z score less than -2 standard deviation, that both should be written for diagnosis of osteoporosis. But for as a guide to treatment, if he says which of the following will be the guide to treatment in the patient, then guide to treatment will be the T score, and the drug of choice for management of patients of osteoporosis would be answered as bisphosphonates. We can be using risedronate, or obviously we have IV formulations also available, which are more convenient, like you could be giving them twice a year. But if person is not agreeing for injections, then oral risedronate once a week would be given. With bisphosphonates, two important side effects should be remembered that even the orthopedician would have told you, but I'm gonna still mention them. One is gonna be osteonecrosis of the jaw. I mean, the person who's taking bisphosphonates underwent some dental work like root canal treatment, and then subsequently osteonecrosis of the jaw occurred. Another possibility is seen with respect to, I would say 3 to 5 years of continuous usage, that there could be a atypical femur fracture. Like this person did not even fall, but still has sustained a femur fracture. This atypical femur fracture, I mean, this is a big disadvantage with bisphosphonate usage. Therefore, he says that, I mean, if you are using bisphosphonates in a patient, you should discontinue bisphosphonates after 3 years. In some books, it is written 5 years, so I'm writing a broad term here. But the point is, because of the fact that bisphosphonates have this huge side effect of causing atypical femur fracture, Therefore, most physicians would stop using bisphosphonates after a duration of 3 to 5 years. We do have other drugs available like calcitonin for bone pain and denosumab, which is a monoclonal antibody that I mentioned even in management of hypercalcemia. Additional aspect which I would like to also mention is that I told you about what is technically called as nutritional rickets, but in the exam in the previous years, to trouble you further, they have also talked about vitamin D dependent rickets. So let's have a quick look at this table, get the facts right for vitamin D dependent rickets as well, that is with respect to type 1 and type 2. Type 1, the vitamin D dependent rickets, this was also previously called as pseudo vitamin D resistant rickets. What's the problem in this case is that the gene which encodes for 1-alpha hydroxylase, I've told you 1-alpha hydroxylase is present in the proximal converted tubule of the kidney and helps in synthesis of vitamin D. The gene that encodes for 1-alpha hydroxylase is defective. As a result of it, what's going to happen is that the synthesis of 125 dihydroxy, the active form of vitamin D I'm talking about, the synthesis of 125 dihydroxycholecalciferol will be relatively lesser. Why? I mean, it's lesser is because the gene which is going to be responsible for doing its job is not working properly. In these patients, if I'm going to check out the report, the traditional rickets report would be present. Calcium phosphate and rickets always go in the same direction. I told you, in general medicine, we usually have as inverse relation, but in rickets, calcium phosphate will go in the same direction. SAP values would be elevated. And when I'm going to check out the PTH, even PTH is elevated. Why? Because calcium is less in the patient. So the traditional report will be given to you. But what's the problem in this patient is that the synthesis of active form of vitamin D is lesser. So he can ask you, what is the treatment of type 1 vitamin D dependent rickets? Well, the treatment would be that you give supplementation. You can reverse all the findings here. It is very easy to treat it. All you need to do is reverse by giving what is produced less. We have is available 125 dihydroxycholecalciferol or vitamin D active form that can be given to the patient, and the rickets component in the patient would be treated. It's the active form that needs to be given. When I talk about type 2, that's actually the true form of it. In this case, the problem is not with synthesis of vitamin D. It is end organ resistance. It is the receptor defect. So today I've taught you two diseases with respect to receptor resistance. One was resistance to PTH. But now I'm teaching you regarding not resistance to PTH. I'm teaching you end organ resistance to the active form of vitamin D, that is 125 dihydroxycholecalciferol that you study. That is not gonna work in this particular case. The laboratory report in this case would also be same, but as such you can understand that treating per se type 2 will be relatively more difficult, in a sense that if the receptor is not behaving, then giving vitamin D alone would not help. So what we do in type 2 vitamin D dependent rickets is we mainly use calcium infusions rather. I mean, traditionally we give calcium orally, but here we load the patient with a lot of calcium, and when we give calcium infusion, it tends to normalize the PTH in the patient. And by normalizing the PTH, at least we are able to reduce the degeneration of the bones, because ultimately the bone reabsorption is via PTH only. I'm not saying that this is a permanent cure. I mean, it's just that you normalize PTH and thereby it will cause an improvement. I mean, if I normalize PTH, the bone pain component and the bone reabsorption component will become lesser. So when it comes to type 2, just like type 2 diabetes has a resistance, similarly type 2 vitamin D dependent rickets is also resistance to vitamin D. That's the only point to be remembered. In PHP, it was resistance to parathormone, whereas in type 2 vitamin D dependent rickets, it is end organ resistance to the effects of vitamin D per se. So these are the details for this discussion, but then calcium phosphate metabolism is usually asked in the exam. So I've invested a little more time in this topic so that you're thorough and you can crack these questions. And I'm very sure with brilliant minds you have, you're going to do great in your careers. Keep hammering, keep the pressure on, guys, and you are going to do and achieve great ranks and great scores.